Good evening, everyone. It's a pleasure to have you here with us. This is Agile East, and today is part 2 of our webinar series for the Not Just a Community Physio topic. So it's part 2 of 2, just so you know. So today you'll be hearing from different physiotherapists who will be sharing about their career journeys and mainly talking about community physiotherapy and sharing and letting us know how broad and how much scope there is in community physiotherapy. So it's such an honor to have you all here. And for those who missed part 1, we had the CSP professional advisors, Jackie Lidgard and Helen Hart. They talked to us about their vision for community rehabilitation. And the session was recorded and it's available on our YouTube channel. So if you search on YouTube, Agile Physiotherapists Working with Older People, you will be able to find all our other sessions, all our other webinars. So we'll put the link for you in the chat at some point. And also this session is being recorded. So if you do not want your face to appear in there, please try and keep your video off. Otherwise, keep your mics muted and only open when you need to talk. So we have an amazing panel today, about five of us, and you'll be hearing from everyone. So for those who are not members of Agile, please, you're welcome to join. We'll also be sharing the details on how to join in the chat. And also, yeah, I've forgotten something else, but yes, do please sign up and join us. So without further ado, I will invite, I'll start with myself. I'll say briefly something about my own career journey. So I am a physiotherapist. I qualified in Uganda and I have worked in the UK for about 15 years, I would say. And I keep hearing people telling me I don't look that old, but yeah, I guess everyone should become a physiotherapist so you don't get to age. So I first did community physiotherapy in the intermediate care service. And I have covered a range of physiotherapy roles. I've done falls prevention. I've done A&E, where I'm like on the edge of the acute and the community, trying to keep people from not being admitted in the hospital. I've done inpatient rehab. I've done falls clinic and day hospitals and different things. And currently I'm working with the enhanced health in care homes. And this is, I've found it to be an amazing role. It was originally advertised only for nurses, but then the AHPs in my trust decided to say that this is a role that physiotherapists had and other AHPs had the skills that they could use in this particular role. So then it was opened out to AHPs. For those who don't know AHPs, it's allied healthcare professionals. And so we were all able to apply for it. So I work with care homes. We support them with we do MDT meetings, multidisciplinary team meetings, and we try to do what we call proactive input, proactive interventions. We try to troubleshoot and see if there are things that might result into care home residents ending up in hospital, and we try to mitigate them. so that the chances of going into hospital are limited, are reduced significantly. So that's the kind of role I'm in. I went into this role because I felt like, yeah, I wanted to try something different. I was like, why not? So I find myself as the only AHP on the team. The rest are nurses. So I bring my AHP skills, my physiotherapy skills and expertise to the team. So then it makes our team that much more richer. So I would encourage people, if there was a role, I would say anyone, to anyone, if they wanted to have a go, it would be I would encourage them to have a go. So I think I will stop there for now, and I will invite, where's my list? I'll invite Jackie to speak to us. Thank you.
Thank you, Justine. Hi, everybody, and thank you for coming. There's a few familiar names and faces, so hey to anyone I know. My name's Jackie. I'm one of the CSP professional advisors for the Southwest region. I grew up, though, in the east of England, and my very first rotational job was in Queen Elizabeth Hospital in Kings Lynn, so I'm very familiar with the east of the region. Just to talk you a little bit through my background, I also qualified a number of years ago, although my grey hair will attest to that. So back in 1999 from Liverpool University, and I went through the very traditional route for physiotherapy at the time of doing my what were junior rotations then in my local acute hospital, learning a huge amount. And at the time, I felt I wanted to go and explore. There was lots of locum vacancy, so I ended up down in the southwest of England locuming, and one of those jobs was a community job. And as soon as I started working in the community, I really felt it was a good fit for me as a physio. I've worked in neurological rehabilitation within the community. I've worked in ESD. I've worked in more generic community rehab teams, and I really feel as physiotherapists, it allows us, the role within the community allows us to use our autonomy, allows us to use our problem-solving skills. We've all been in those situations where you get there and the patient is on the floor in the tiniest space, and what are you going to do? Or you're able to look at the equipment the patient's got around their home and look at how they can do their exercises or their rehab program within that environment using things which are familiar to them. So I really feel it challenges us in the community, it stretches us as physios, and we get a good connection with patients. We get to know them as people, their families, their goals, and work with them towards it in a way that we really don't when we're in hospitals and in a more artificial setting. So that's how I came into the community. I stayed in the community until I moved into the CSP. And for me, working within the CSP, I'm going to give a plug now to the fact that we're releasing our new community rehabilitation standards next month, which I'm very excited about. So if anybody wants any of the professional advisors or any of the CSP staff to come and CSP is Chartered Society of Physiotherapies, George. Sorry, it's the professional body and trade union for physiotherapists. So apologies for assuming everybody knew that acronym. That wasn't great of me. But we're releasing our new community rehabilitation standards. So I'm really happy to share details, and if anybody wants me to help them to organise or put them in touch with regional representatives to come and talk about those standards once they're released, we can do that. But we've worked with a number of other professional bodies and community organisations, Headway, Stroke Association, to develop those standards, and we're hoping they'll provide a real guide for physios, for commissioners, for managers to help us drive quality community rehabilitation forward with physios at the forefront of that. And that is also part of what I love about community rehab. In the 20 odd years that I've been a physio, our roles as physios have changed and developed so much. We've got prescribing rights, we're moving into advanced practitioner roles, and I really feel community offers huge opportunities for us as physios to be able to develop into those advanced practice roles with prescribing, leading teams within frailty, within falls rehabilitation. There is a lot of opportunity for us to develop and use our skills even more. And on the other side of that, there's also great opportunities for our wider membership and for our support staff. So for me, I have, as a junior physio and as a newly senior physio, I found it very hard to let go. The longer I've been in my career, the more I've realized that we all don't need to do everything, and that especially within community, there is enormous opportunities for our support staff, whether that's running community-based falls classes, the development of assistant practitioner roles, the therapy assistant practitioner roles, that we have unqualified staff able to carry out some of those simple assessments and lead treatments, and to really have a good team around you of qualified, unqualified staff, and everybody. We can link in with the wider MDTs, whether that's with urgent care response, whether that's through virtual ward settings, to really showcase what we can do as a profession and how well we work with everybody else. So I'm coming almost up to the end of my 5 minutes, and I can talk too much if I'm allowed to rabbit on. So I will be quiet and hand over to the next person. But for me, community rehab is a great place to be a physio, a great place to develop, and a great place to show as a profession what we can do.
Brilliant. Thank you so much, Jackie. That was brilliant. If anyone has any questions for Jackie, please feel free to ask. You can put your hand up, or if you have questions for any of the other speakers, you can put your hand up, or you can type them in the chat and they will be directed to the right person. So next we are going to hear from Aileen. Aileen, over to you.
Hello everyone, can you hear me all right?
Yes.
Yes, excellent. Yeah. So I'm Aileen. So I'll tell you a bit about my journey in physiotherapy, which kind of leads on from what Jackie was just saying. So that fits together quite nicely. Thank you, Jackie. So I also qualified a little while ago in Scotland in 2003, and then I moved to England immediately. I completed my junior rotations, much like Jackie, in Medway. For those of you who know Medway, know how much fun that was. And then I became the first junior / band 5, as it would be now, physio to go out into community physio, into the community physio team. They hadn't put a junior out into community physio before, so I was the test subject, and it went really well. And I think as soon as I got into the community, I thought, this is where I want to be, which surprised me as much as, you know, anybody, because I would never have thought as a student that I wanted to be in community physio. I always thought I wanted to do pediatrics until I did my elective placement in pediatrics and realised I definitely didn't want to do that. So it was lovely to find that place where you think, oh, this is me, this is where I want to be. I loved being, you know, a bit more flexible in managing your own time and being with patients in their homes and seeing real situations and being able to actually make a difference. So I ended up staying in community physio as a band 6, and after about a year in community physio, I then started supporting the band 7 at the time, who did a 50-50 role between community physio and palliative care, supporting our local hospice, which is an NHS hospice, so it's a bit unusual. And then I started doing more and more time in the hospice until eventually I became the band 7 at the hospice instead. So although it's a slightly different role, there's quite a lot of similarities between palliative care physio and community physio, because it embraces all of our skills in much the way that community physio does, you know, lots of neurological, lots of, you know, elderly rehab, lots of respiratory physio. So they're very similar in that way. I completed my master's in supportive and palliative care in 2010. And just a little plug for the professional networks. As soon as I started working in palliative care, I joined the Oncology Palliative Care Network, and I was in their committee for about 10 years, including being chair for about 5 years. And it's just a plug to say the professional networks are such a good place to get support and link in with people, especially if you are, you know, a lone practitioner and maybe don't have a lot of support from day to day. So I was at the hospice for about 13 years before I decided to make a change just for something different, and I moved into primary care, where I am now, where I work now as an advanced practitioner in frailty. Part of my role being care homes, so I look after 3 care homes, and also visit people at home to carry out comprehensive geriatric assessments. And since I've been in this role, I did complete my prescribing before I moved roles as well, and I've since then completed my PG Dip in advanced practice and the RCP geriatric diploma. So if anybody's looked into doing that, who's working with older people, I'm happy to answer any questions. It's definitely a challenge, but I think worthwhile doing. So although in my role now I'm not doing sort of hands-on physio, I'm still using all my physio skills every single day in terms of my assessment skills, my diagnostic skills, treatment skills. I still give lots of physio advice, even if I'm not officially doing it as a physio. And it's kind of nice. I think I've kind of found my way back to working with older people, just like I did at the start with Community Physio, and that's why I loved it so much, was because I loved working with older people and working in the community. So and just as a sort of, obviously, hopefully that explains to people like other ways you can go. So you may be quite happy just working in it as Community Physio as I was, or there's lots of other opportunities out there now for us in advanced practice, which is the road I've gone down. And yeah, it's about getting involved. So I'm a bit terrible for having to get involved in everything, which ends up, me having too much to do. So as well as, obviously, I'm on the Agile committee as the co-agility editor. Next month, I'm starting the NIHR PCAF fellowship. And I'm also the chair of the British Geriatric Society for South East Thames. I'm not suggesting that anybody goes on with having the problem I've got of having to get involved in everything. But it's just to say there are lots of opportunities out there to expand your role and your networks and see what other places are doing. And there's a lot of other professions, particularly within the BGS, that are really keen to support physios and get physios out into different roles and start making changes for patients. So I'm happy to answer any questions. I've been going on for longer than 5 minutes, Justine.
It's okay. I'm not sending the police after you. Thank you so much, Aileen. I can identify with that fact of joining different networks and taking on different responsibilities. I am Agile East rep, and obviously I'm a member of the BGS, British Geriatric Society, and I am a member of the CSP Equality, Diversity, Inclusion Committee, and all sorts of other things. So, but the beauty of that is I have gained a lot from being on these committees. I've learned so much, communication skills, teamwork, and all sorts of things. And obviously making connections and making friends with lots of different people whom I would have never gotten into my circles. So Eileen, I think I do identify with you, and I would say to members, if you feel you would like to get involved, you might be afraid that it's going to be too much, but again, if you think about the benefits, they sort of outweigh the busyness and the stress and whatever else comes with the responsibilities. So I will hand over to our next speaker, who is Nimalene, please.
Hi guys, can you all hear me okay to start with?
Yes, we can hear you.
Oh, that's great. I'm kind of on my fourth device actually. So it will get going. Okay. Hi, I'm Nima. I'm a physiotherapist. I think just like others, I think I qualified in 2004, a while ago. I didn't prepare that far ahead. It is, community wasn't my option as a student. I never thought I would enjoy community. It was something I thought, oh, I had to wait for buses, and what a waste of time, not just seeing a very few people in the daytime. I think as a student, my interest was neuro, which I still do have that interest. And I was doing older people, amputee, and oncology. So those were my mix as such in terms of doing it. And then I went into a rotational junior thinking that I will actually be doing all the rotations possible, so I can get a ground understanding of everything and anything to make that happen. And the trust I worked for, Needham General at the time, had 4 monthly rotation, which is clearly good in a sense that we can kind of like cover quite a lot in that 4 months of each rotation. And I think my first one community rotation after about like 1.5 years or so, I was kind of reluctantly put myself through to that, saying I will do it just as once to know what happens. Completely changed my mind, obviously, because ever since that I've only been doing community and nothing else. Suddenly realized how much input and how much change you're making in a person's life there. And that kind of really opened my mind, and my whole idea of community changed, because all the other 1.5 years or more of me doing other grounding work all came in handy in the community. There wasn't one discipline I was working with. I started with the general committee, so I was touching every single aspect of that. Changed ever since that. I literally just asked for community rotations. So doing falls clinics, neuro rehab in the community, learning difficulties. So it kept on in the community until the fact that I was kind of like running out. And I wanted to do the pediatric community before I left, which I think it was just, I was lucky enough to have all the community rotations done. Then I got an orthopedic inpatient, which I kind of thought, I can't do this anymore. so I actually went on to getting a senior 2 job role in a community rehab in Camden, and knowing that they were going to start a stroke red stream there, which is something, my interest in neuro and community is the best. The community rotation neuro was my ideal one. So I thought I need to position myself there to get that through. So I was in Camden rehab, and when the stroke rates did set up, I did apply for the post and I did get in. So it was something that kind of like I was kind of gearing towards going into community or rehab as something that I was interested in neurology, but community setting to kind of see the differences I was making. Things changed. I went back part-time after having a child, and that kind of like shook in terms of how stroke rates in Camden at the time, it was one of the pioneering things, and also to kind of like go part-time wasn't an option there. So again, going back, I said, okay, I'll go into the reablement, which was again something that was being set up near. Again, reablement, you saw everything and anything in terms of community settings. And then moving on again, when the school starts, this is my selling my work-life balance here in there. I was thinking I can't really travel all the way to Camden each time and coming through. So I ended up looking for jobs near where I live. And it was a public health job advertised in NHS jobs that I saw. I was never thinking about leaving NHS. That was never an idea that I had. But that job really answered my questions, because all through my career, I have been doing lots of projects, small projects, studies, but everywhere I kind of worked, it was one of those things that were really, all my seniors, managers always kind of like encouraged doing that. And I was really interested in doing things. So this one seems to be a new project of setting up an osteoporosis service in Kingston Public Health. So the idea really triggered, and everything else really suited, other than the fact it wasn't the NHS as such. So that was my only concern at the time. And I had another job around the same time from a different setting of a social enterprise. So I had to ask them for a week permission to kind of literally think it through, because I was thinking I'm going to lose my one-to-one contacts, the actual there, but then I'm going to be doing a lot of prevention role, which is something I'm always doing through my career. And this is, I'll be in an ideal position to have pathways made on that to make that happen. So I did take my time, took an extra 1 week just to think it through, whether this is a decision that's going to be right for me. And then I took the leap after talking to a few colleagues and friends there. So I'll do it, I'll give it a choice, see how it goes, and then I'll decide. And I'm still here after 8 years. So, and I'm not a person who sticks on the same job after 3 years. So every 3 years I tend to change. And this is a job when I started, again, it's setting up things are always my fascination. So it was quite nicely started. Around end of 3 years, I think I remember telling my manager saying, actually, this is the time I normally get bored. So I need to find something different to do. Public health kept changing. Cost cuttings are happening everywhere, and different reasons of different changes. So it kind of gave me more and more new things to do. COVID came then, and obviously we all ended up doing more about, are they getting enough food? Are they getting their pharmacy medications through? So our job roles kind of really changed in terms of looking after the older people within Kingston Public Health, Kingston Borough. And we kind of moved from there to thinking, are they doing enough exercise? They're all told to isolate, and we know what happens when people are going to isolate. So we ended up just kind of like coming up with online. It started off with online links that being sent and letters sent through post with exercise sheets and stuff to every single residence around a certain age. And then it moved on to doing online exercise classes for anyone who had the email address. Again, we have moved on in terms of how we started doing. Last year, we got a funding for doing some exercise thing with volunteers going into people's home using an app to do exercise for people who couldn't get out of their homes. So things have been always exciting. There's more and more new projects, and currently I'm thinking about, again, another 2 different projects that we are thinking of, kind of looking at. So we have used the Good Boost app in terms of helping us do this. And we are kind of like trying to see if we can do something with hydrotherapy, an app. In terms of me telling about public health, I think if you're looking at prevention, if you're thinking about like doing changes, help people motivate and do stuff to kind of change people's behavior and things, it's a really nice role to be in. And even though I do tend to do a lot on the older people's, I do kind of come under the physical activity as well. So we kind of oversee people, and we used to have links with school workers as well at the time. I can't actually see a lot of chats, but I could see them flopping, and someone asking about who can't do the online. So that is how our home exercise program started. So people who didn't have access, but obviously we don't have capacity to have that many staff to go out into people's home to do exercise. So we actually ended up recruiting volunteers who were previous exercise class participants of mine, as well as colleagues from the council. From different areas. They don't have to know anything about exercise. We use the Good Boost app, which came up with the exercise program tailored to that person, depending on the input that the person was giving. And we put the exercises more as a strength and balance exercises to kind of, because we thought like we are going to get more for people who are either quite old and frail, and it was specifically for people who couldn't get out of the house for whatever reason, but need some exercises to get them going. So yeah, so that came out as part of the fact that there are face-to-face classes have started since last September. Everything is open now, but then we do have online options for people who couldn't, but the ones who can't do either, they're still endless going through. I think I'm going quite over in my timing, so I could see the thoughts, but maybe kind of like we could kind of ask these questions to me afterwards. Justine, I can't actually see the chats, but I might ask you to ask the questions to me afterwards, if that's okay.
Sure, that's very fine. Thanks so much, Numa. That was brilliant. We will quickly hear from Joe, please.
Hi, thanks, Justine. Hi, everybody. My name's Jo. So I'm a community physio who works out in across sort of Bexley and southeast London and Kent, and I work privately in a team of private physiotherapists. We have a mixed model of people who pay for us directly, but also have other clients who are paid for through their claims, and we work with very closely with case managers for that. So I'll give you a very brief background of where I've come from. I graduated around the turn of the millennium, and I did junior rotations, very similar to others. Once I'd had an opportunity to taste the community away from the acute sector, I realised that was my place to be, and I went and explored very much in the intermediate care model of sort of model of care that was very much centred around admission avoidance or reducing acute hospital stay and length of stay. Whilst I was out in the community doing those roles, I completed a MSc in rehabilitation, and I took a number of roles as my career progressed into more leadership, service leads, and at one stage I headed up for a local community service, allied health professionals from a sort of quality perspective, and in a way of being able to then get back to doing some clinical practice, because it was important for me that as I progressed in my clinical career, I also wanted to, or my career, I also wanted to make sure that I retained and wanted to be a clinician, because that's why I was a physiotherapist and trained to be a physiotherapist. And having done MSc in rehabilitation, I realised that was my key area, was that I wanted to continue with rehabilitating people. So I took a role in an acute sector from a frailty perspective, but for me that wasn't the role that was suitable to my interest. I wasn't able to achieve the rehabilitation that I wanted to do. We were doing there was opportunities to do comprehensive geriatric assessments and things like that, but for me I wanted to actually be setting the goals and rehabilitating people back out into the community, which was when I, along with a colleague, set up our company. And we've now got a large team of physiotherapists who are out seeing people for a nice long length of time in the out in the community. So I think I guess for me it was sharing with you is why I want to stay in this role and what this role really brings to me, and why I've sort of I've refound my love for physiotherapy through this role. Because I'm actually able to spend lots of time with clients and really flex those rehabilitation skills that I've grown and developed over my career. And also for me, it's also about the prevention and also the long-term management of conditions and preventing the frailty. So in my frailty role, I was very much seeing the severe end and the progressed end of frailty, whereas I'm really keen on seeing people right at the early stages of Parkinson's, perhaps early stages of frailty, early stages of long-term conditions, where we can have a real impact and set a way of preventing and slowing down some of those conditions. And it's not just final symptom management, it's actually managing the symptoms and controlling those symptoms through exercise and all of the other adjuncts that physiotherapy can provide. So we have we are predominantly a senior-led team, so majority of our physiotherapists are 5-10 years plus experienced, and majority of us do come from an NHS background, and majority of us people who want to continue doing our rehabilitation but want to work at a senior level as a senior clinician. We spend about 45 to 60 minutes with most of our clients and most of our appointments. We see people both at home but also out in their care home settings. And I guess the point for us is that every visit and every time that we see somebody, it's about value and providing value for that person and making that real purposeful rehabilitation, really understanding exactly what they want to achieve in that session or that group of sessions. And quite often we're the first point of contact for that person's been able to have for a healthcare professional. So we're responsive and often the first person they can call. Essentially, it's a Google, find us, telephone us, and then we go in and see that person. So we're often seeing people before they've even had a chance in these times, perhaps even to see their GP about some of the symptoms that they're having. So a lot of work is fed back into advising, feeding people back into diagnostics, or feeding people back into GPs and to consultant geriatricians, etc. But quite often we are actually picking up and starting to diagnose things that we're picking up: early stages of Parkinson's, early stages of MND, etc. Because they come with us with a problem, and then they want to have the solution, but sometimes that problem hasn't had a diagnosis. So we support that person, and with their consent, obviously, their family through that process. And it's really building up that partnership with the patient and their family, if they want that, so that we can really work together to achieve what that person wants, but also making sure that they're fed back into services if they need those diagnostics. So we always make sure that we're very safe practice, but I would always say that we're quite ambitious physios, very ambitious in wanting to and work with our patients to take them on a nice journey to achieve greater things. So I would say probably the thing that I particularly love about my role is that, yes, we go in, see somebody, might be the first contact physio, we may be doing first contact tuck physio, and we're assessing that person, identifying what their problems are, dealing with that acute situation and managing that. But most importantly, we're taking them on a direction of being able to prevent it from happening again. So just give you a bit of an idea of maybe my day to day. First thing, I was doing a Fit Move class, which is a class where we support people with, I guess, early stages of frailty. And the idea of that is providing them with muscle strength exercises, cardio exercises, and balance training. And then I was off into a care home looking at seating arrangements for a palliative care lady and making sure that the care home were able to get her in and out of her chair. So just sort of give you the diversity of this role. Then I was off to see a patient over who's got access to a gym and swimming pool. I'm an aqua therapist as well, so we were in the pool doing exercises with him. And finally, I was out seeing a chap who I've seen for a long time, who I was one of the first people actually to identify some of his Parkinson's symptoms. I've been with him for a while, providing him with an hour's worth of exercise, which he obviously wants to do as a way of sort of symptom management and slowing down the progression of his Parkinson's. We were on his exercise bike, and then we did some circuits within his own home, both from a sort of muscle strengthening perspective and also some cardio work. And that was my day. Then I came here. That's it. Have I gone over 5 minutes, Justina? Is that all right?
You've done really well. Thank you. Wow, that's a real marathon. Thank you for taking us through your day, Jo. And last but not least, we're going to hear from Alex. Alex, over to you. Thank you.
Thank you very much, Justine. I am Alex Mackenzie and I'm chair of CSP Council. But in my other role, I am actually clinical lead in acute physiotherapy. So never mind imposter syndrome, I'm a complete imposter on this panel because I'm not a community physio and I've never been a community physio. I've always worked in the acute hospital, having spent about 19 years working on an acute oncology hematology wards before my current role, which is day-to-day management of about 60 staff based in the acute hospital. So very good question is, what am I doing here? Well, Justine and I had a conversation at the Equity, Diversity and Belonging Committee meeting, and we're talking about the importance of community physio. And I was telling her why, from an acute point of view, I think it's really important that we have good community services. So she asked me if I would come along and talk briefly about that. So I am passionate about community physio because it is about getting patients out of the hospital and getting them home or to a homely setting a lot quicker. I mean, being in the acute hospital, it's not the best place to be at the moment, ambulance stacking, patients and trolleys and all the rest of it. And we know that with staffing shortages generally, patients are not being encouraged to get up, they're not being encouraged to do much activity, they're not necessarily doing that much for themselves because it's far quicker for potentially the nurses or the healthcare support workers to just go in and help them, give them a wash, get it done quickly, move on to the next one. So it's not the place where patients actually pick up their activity levels particularly. And if we go in as physios and we're spending 20 minutes, even if we get the opportunity to spend a lot more than that, there's still the whole rest of the day where they're potentially just lying in a nice bed doing nothing else. Whereas if we get them home quicker and we get community services into them, then they start doing a bit more. They're encouraged to do more simply because they're at home. They will potter, they've got their own things around. And by doing the treatments that you give to patients at home, they also see how it can fit in their daily lives rather than it being just a something else and a sort of adjunct. And as a acute physio, I have to say it is a source of frustration that the underfunding of the community services, that the services aren't there for us necessarily to be able to refer out to. I mean, you know, our community services linking in with sort of GP, all that primary care should be the absolute bedrock of the NHS. Whereas at the moment, a lot of the sort of sources of funding, the modernisations type of thing is all being put into the acute hospitals, because in a way you can neatly wrap up a package of care in an amount, and that's easier for services to be commissioned than some of these the services which are actually fundamental to adding value to people's lives. So, you know, in terms of that, you know, it's interesting that a lot of sort of developments at the moment that we see, particularly in the acute sector, are all about sort of getting people out quicker, getting people sort of discharged. And I think it is important that our community services are changing, are developing, are improving to be offering, I'm going to say, all those things that colleagues here have already sort of talked about, you know, those very different things, you know, providing respiratory services in the home, providing proper neuro rehab from the get-go into a person's home. It's where they're more comfortable. And also then it's things like the hospital at home services and some of the A&E and front door services, which again can be sort of in reach rather than just being sort of somebody seen quickly and pushed back out the door. I think there's lots of opportunities for community services to develop and to be able sort of to take on the level that I think is really important for us to have. I mean, going to hospital should be the exception, whether it's actually as an inpatient or an outpatient. You know, we need to be starting to take people away from the hospital setting, because it's more about actually people understanding that that there's an element of what it is in their control, what they have to do. Going into hospital does tend to make patients become very passive, whereas actually by doing more out in the community and by making it more people's way of life will help make them more active in their own treatment and in what they can do. So we really need to make sure that we as a profession are improving sort of community rehab and our community services. You know, and in that, I think we have a real valuable role in ensuring that we promote and value the skills and versatility that is required to be a community physio. And I think events like this are really helpful in that. I mean, I had a really good example today. Obviously, I do go on quite a bit about community services because I was actually chatting to my daughter this evening. Now, she's a electronic design engineer, nothing to do with health whatsoever. And we were chatting about our days, how they'd gone. And I said to her, I'm doing a webinar on community physios this evening. And she said to me, well, of course, rehab is the backbone of the NHS. And community rehab is even more important because it reduces the strain on the NHS. And I said, that sounds great. Where did you get that from? She said, Mum, you're saying it all the time. So I was like, okay, clearly I've indoctrinated somebody who's nothing to do with health services, which is not a bad thing. So I really just wanted to say I'm really enjoying listening to all the different stories of the other presenters and where they've come from and where they've you know, how they've made that journey, because I think it absolutely outlines that there's no one journey. And I think, you know, a lot of people dip in and out of a variety of different things. And I think it's been really great to hear all of that. I'm going to make one little plug as well. Jackie was talking about the rehab, the community rehab standards that are coming out. There is also on the 19th of October, the CSP's, it's a summit. So it's a hybrid event. And you can register to be online, and it's called the Complexity Challenge, and it is also talking about sort of community rehab. There's a number of different panels who are talking about different aspects, but actually community rehab is also at the heart of that. So if anybody's interested, it's a free event on the 19th of October. So do sign up for that as well. But thank you very much for having me here.
Amazing. Thank you so much, Alex. It's been lovely listening to you. So that's our speakers. That's the speakers we had today. Now we are going to go into Q&A, questions and answers and comments. So there are a few comments in the chat. I'm going to invite George to say something because George, you've typed a few things in the chat, haven't you?
Yes, yeah, but I've been very busy. And I just want to say thank you. I mean, you and I are already Twitter buddies. We've never properly met, but I regard you as my go-to expert, Justine. So amazing. And thank you for having me along. I feel I'm a sort of the outsider within your group. So I feel very flattered to be able to listen to you. And I feel very inspired and enthused as I often get. And I'm scribbling mind maps like a maniac here with all sorts of ideas and thoughts about how we might be able to further collaborate. Because I mean, that final point that I've just added about how do we make time for reaching out to one another? Because I think care homes, my care homes, we don't see enough, if any, physiotherapy support. It's often very finite. It's very, someone made a point about the length of wait times and so on. And I know everyone's really busy, and I just wonder how we can make headroom and make space for doing innovative, exciting co-production work. Because you know, I made the point earlier, Justine, about not wanting more training. You know, we for lots of reasons, we need to be working together in partnership because we don't want our residents falling over, despite knowing that we can't entirely stop them. We do want to be thinking outside the box and doing more. So I'm really, really interested in you and I and others continuing the work we did many, many months ago, if you remember, when we started crafting a sort of a toolkit or a workshop manual about how we can address better empowering staff in care homes and being more sort of able to do more. So you know, I'm saying too much now, but I'm just really grateful for being here, and it's very inspiring. Really interested in where Jackie's working in the Southwest and whether we might be able to sort of find a way to do some co-production, you know, thinking about fall prevention particularly.
There's certainly, George, some linking in with, if people aren't aware, your local networks should have an enhanced health for care homes lead. And I would really encourage you all to find out who those people are, linking with them. And there's some great work going on. There is work around using some technology and those of things, and it's sharing across those networks. And I think we also thinking a little bit outside of the box. So are there people that you said it's not having training, but can the care homes work with you to be able to deliver some of the physiotherapy, families, volunteers, all of those kinds of things? So we're saying, you know, spreading that load and everybody having that responsibility for falls prevention. And I know certainly there was some work going on with technology within the Southwest. So if you want me to drop you a line, George, I can have a look at that.
I've been very involved with the Enhancing Health and Care framework for years, really. It's not new. I've presented at conferences and so on about it, and I'm quite well plugged in. But I think the use of technology is something that we're looking at and trying to develop. So yes, please, I'm very interested in any resources and any ideas that can be shared. So yes, please, yes, please. Thanks, Justine.
Thanks, George, and thanks, Jackie. This is something we were discussing with a few other members of the committee. The fact that our patients, they have us going in to see them, or if they're in the hospital and they are lucky, not lucky, but if they get to have physiotherapy, they get that and then they start to improve, then they're discharged and then they don't do anything. And like there's no continuity. So George, what you're saying about co-production and collaborating and working together is really important, because if we could have a handover of sorts to somebody who can continue doing some work with the patients we see, that would make a massive difference. Yeah. So are there any questions in the chat, Ritu?
No,
Or
there are no
any-
questions. There are no questions.
anything?
There were a few comments. Obviously, George has spoken, and I think there are a couple of colleagues here who are going to get together and potentially be part of the kind of the north side care home work. And I
Okay.
think Eileen has said she might be interested in something like that as well.
Oh.
I guess if there are any participants tonight who potentially want to share a little bit of their journey, something interesting, exciting that might inspire the rest of us, then please feel free to unmute and share your journeys with us as well.
Thanks, Ritu. So I had a question. Okay, I had a few questions that I wanted to pose to our speakers. So would you kindly share some of the challenges you have encountered in your career journey or in your current role, and how you've gone about them? And also I'll just say all of it and then you'll pick what you feel like talking about. Then if you could also talk about any support you've needed to get into your role or any past role, and where did you get that support from, just in case someone here is also wondering about something like that. Yeah, so I'll ask just those two for now. Who would like to go first?
I can go first if you want. Justine, can you
Sure.
remind me what the first question was? Because I've forgotten already.
Any challenges you've experienced in your...
Oh, okay. Yes. Well, probably in my current role, in my ACP role, probably the biggest challenge has been sort of educating people to the fact that physios can work as ACPs in something that's not MSK physio. So when I first started in my role, most people would refer to me as the frailty nurse, which I had to sort of knock out of them very quickly. Not that there's anything wrong with nurses, obviously, but I'm not one. But I think very quickly, the GPs in particular realised the sort of range of skills that we have as physios, particularly in terms of our autonomy and our assessment skills. I don't think GPs particularly have no idea about physio training. And when they realise actually we're autonomous from the day we qualify, they realise that we've got lots and lots of skills to use. So sort of educating people about the fact that physios, and now in my team we have another physio and a paramedic, both all advanced practitioners in frailty, and none of us are nurses, and that's kind of surprises. So now we normally get referred to in our care homes as the doctor rather than the frailty nurse. So obviously still not right. I suppose I could, as a sort of a promotion, I'm not sure. But it's very difficult to explain to patients what you are, like, and if you say an advanced practitioner, they're like, what? And if you say they're a physio, they're like, what are you going to do? You know, because they're complaining about their constipation or whatever it is. You know what I mean? So that probably is the biggest challenge in my current role, I would say. But it's definitely getting easier the more advanced practice is developing with you know, more physios being in advanced practice. It's getting the message is getting out there, I think.
Brilliant. Thanks, Aileen.
Okay. I can go next, Justine, if you want to.
Sure.
Someone else has put through. I think the main thing for me, the challenge is almost, no matter where you are, is the cost cutting, and every single time something changes in terms of how much funding you're going to get for anything in there. So it's kind of like, I mean, one of the questions someone did ask, like, oh, how public health giving all this funding, it doesn't come from public health, unfortunately. It is about kind of finding the gaps and finding different resources. As I mentioned, using a lot of volunteers who have either participated in the programs themselves, using colleagues, as if kind of like, it kind of with the COVID, it really helped of using our colleagues, because it gave them a chance to kind of get out and do something
and be happy about what they were doing. So you're helping an old person at home who's very lonely. You don't have to do anything about exercise because that part is covered, but it's that, and they all kind of like, and one person came back and say their experience, then it kind of went on after that. So yeah, so challenges in terms of it's the resources getting that, but it kind of have made me more and more into how much I can chop out, what local organizations can I tap into, even the residents as such. In terms of what has guided, I think everywhere always had the support of the seniors and the managers through in terms. So sometimes they come up with say like, I would really like to do this one, but really don't have the time. How do you kind of manage this? So again, coming ideas from them as well. For me, I always tend to do a lot. It's kind of like, and then I am kind of like coming more and more into kind of thinking, okay, I need to kind of have my work-life balance here, because you feel there's a gap and you kind of somehow want to kind of fix this, but you know it can't. So you want to try and take those steps. So it's kind of like understanding your own limitations, I think, in one point is also the barrier there. Just understanding and saying, okay, this is all the resources we have, and therefore that's what we can manage. We can't, there has to be a give there as well. I'm going to stop with that.
Brilliant. Thanks, Nima. So if there's anyone who can answer the second question, we're sort of running out of time, but if we can answer that quickly.
Justine, I was going to add in for the challenges a couple of challenges that I find, if that's all right. Is that okay?
Okay. Yeah,
I haven't got anything for the second question though, but I was just going to say that just to remind everybody that there is the CSP have got a guideline on collaborative working with different physiotherapists. So one of the challenges that we sometimes have, not so much now because we can signpost, is when we're working collaboratively as private physios alongside NHS physios, just reminding people that as long as we're working the guidelines, we can all work well together. And I'm probably one of the other challenges that I had possibly earlier on in my career around clinical reasoning. I found that a lot of my clinical reasoning, a little touching on what we were talking about just now about resources, my clinical reasoning was very much dependent on the resources and number of visits that I was allowed to go in and see people. So I was almost thinking, actually, we're not going to be able to achieve X, Y, and Z with this person within 4 sessions or 6 sessions or whatever it was that this service that I was working in was able to provide. And the reality was, therefore, that I felt as though I was stunting their rehabilitation goals. But now, at the present time, I'm sort of, that was one of my reasons why I sort of wanted to look at other opportunities to actually progress their goals beyond just, and my clinical reasoning is very much changed now from that perspective.
That's great, Jo. Thank you so much. So this other question about support, I think it would help if someone could answer, could shed some light. So what support have you had?
I'm happy to go for that, Justine, so I can talk about some support that's out there. So I think it's really important to find sort of someone who can mentor and model you and show you where you can go with your career. And again, shameless plug for the CSP's mentor service which we run. You can sign up to be a mentor or a mentee and look for somebody who's worked within those areas, or look for somebody in the roles that you want to aim for, and ask them how they got there, ask them what their journey was. People generally love to talk about their career and how they've done that. And I think you can also look outside the field of physiotherapy as well, particularly for people in advanced practice roles or looking to step up to develop their skills. Don't always necessarily focus on community rehab. Look at people working in advanced practice in other areas. Physios have got lots and lots of transferable skills. Look into your professional networks. We've got 28 professional networks throughout the CSP that cover, as people have said, we've got agile, we've got oncology, that cover an absolute wealth. So there's always people around there who are willing to share how they've got there and, you know, their own journeys. But in terms of needing support clinically, I think if you're looking for training or looking for more staff or anything, it's really, really important, particularly within the community, that we're looking at gathering data, we're looking at gathering stories, and we're being able to present a really rounded picture of our services and what you want and how you're going to get there. So if you're saying that you need additional staff, can you demonstrate that with some data that shows if you had this person for this amount of time, the amount of visits? So it's really building up those pictures of your services, getting the feedback from the patients. If patients in one area have a great falls class and are giving some amazing feedback, can you take that and ask if you can replicate something similar, so that you'll say you want to be able to showcase what you do, but you also need to be able to evidence that with some data from your services to be able to present your needs, give your evidence, and then ask for the support that you need to be driving your services. So think about it from the two ways, the personal development side and then also the service support that you need. And hopefully, again, shameless plug, our new standards will help with that and will help you to be able to audit, to be able to gather some evidence and be able to show where you're doing really well as a service, but then also show maybe where you're not quite hitting targets, but we'll be able to demonstrate how you can gather that evidence to support that you need more or you need something different. Hopefully that
Thanks
answers the
so much,
question.
Jackie. Yeah, you have. Thank you so much. Alex, did you have something to say?
Sorry, I can't even find my mute button. That's never very good at 8 o'clock at night. No, I mean, I think, you know, just listening to all of you, because obviously you've got the experience of actually having worked in the community area. I think is really important. And I think, you know, I would have plugged the rehab standards if Jackie hadn't been here to do it so eloquently anyway. But I think I think they'll be really good when we see them coming out. There's a lot of collaboration that's gone into that, and I do think now is the time. I was seeing tweets earlier about some of our CSP staff talking at the Conservative Party conference about rehab and getting quite positive response as well. So now is the time to be sort of grabbing some of that in terms of promoting that brilliant aspect of the profession.
That's brilliant. Thank you so much, Alex. Eileen, your hand is up.
Yeah, sorry, you know, I've always got something to say. It was just to add, really, in terms of if you're looking for, you know, support, just whether it's to, you know, for your role or developing your services, I would say just make sure you look beyond physio, other physio support as well. Get the medics involved, get, you know, other therapists involved, get nurses involved, because there's also there's usually a lot more strength behind more than just one profession asking for something. So you know, because you just tend to get more clout, especially if doctors are involved. For that's not necessarily, you know, the way it should be, but it is the way it is. And definitely getting my GP's supportive of sort of frailty and the work we can do has made huge advances. I don't think we would ever have made, you know, if it was just physios just trying to plug it. So get as many people that will listen to get involved.
Thanks, Ellen. Definitely the talking about what you wish to do, I totally agree. So for me, what has worked for me, I could say it's being willing to learn, putting myself out there, having a go at things, being bold, like being an overseas trained physio in the UK. You can come with your own complexities and your own how do I put it, your own like lack of confidence and putting yourself down. And not just overseas trained physios, but all of us, we all have that little voice that can try to pull you down. But I think what has helped is just having a go and being brave and putting myself out there. And I think being part of things, I'm going to say things, has helped a lot. So like being part of the CSP, being on the Agile committee, for example, I have done some guest lecturing. Hooray! I've done some guest lecturing at 2 universities, UCL and Bedfordshire, University of Bedfordshire, teaching physiotherapy students. And I would have never thought I could do that, but being being with Agile and being vocal about physiotherapy and about Agile work and about frailty, people approached me and they were like, do you want to do this? So these are opportunities that come your way when you come out of your shell. And I still have moments of wanting to hide away and just be quiet. But I think in this era, we need to put ourselves out there, and also expressing my dreams, my vision, my like what I want to do at my workplace. So with your manager, when you're talking through your annual appraisal, just tell them what you want to do, how you want to progress, what area you're interested in. And when, like this current role, my line manager saw it somewhere, heard about it, and she came and told me, Justine, we had just had the annual praise, and I told her I wanted to go into leadership, but I didn't necessarily want to be like a team lead. So she came and she said, oh, I heard them talk about this role. I think it would suit you. And I applied and I got it. So but be vocal about where you want to go. Yeah, have mentors, and yeah, that's about it. So yeah, volunteering, it's going to cost you time, obviously, like being on the Agile committee. It costs me time, it costs me energy, but again, I can't put an amount on the benefits I get out of that. So yeah, I think that's all I can say. Thank you so much for being here, all of you. It's been such a pleasure, such an honor hosting you. Thank you to all our panel members. You've been awesome. Eileen, Alex, Nima, Jackie, and Joe. Thank you so much for sharing your experiences. Thank you everyone who has been here. Thank you, Agile East Committee, you're amazing. And the Agile National Executive Committee, thank you so much. And for anyone who is here who still has any question, please, you can email Agile or chat, send us, slide into our DM on Twitter, and we will answer your questions or respond to your comments. So thanks again. Thanks, Sarah, for your help. Thank you, Ritu. You've been a star. Thank you, everyone, and have a good night. And yeah, let's keep on being confident, knowing that we are not just a community physio. We are just amazing physiotherapists. Thank you.
Thank you.